Welcome to today's deep dive. We are tailoring this directly to you, the plastic surgery residents out there preparing for board exams like the FRCS. We know your time on the wards is incredibly valuable, so we are getting straight to the point.
Absolutely. We are keeping this strictly focused on high-yield clinical application, no fluff.
Right. Today, we are unpacking a massive stack of clinical literature detailing the management, the underlying pathology, and the heavy-duty surgical reconstruction of pressure ulcers.
And we want to arm you with a conceptual understanding that really goes way beyond rote memorization for your boards.
Exactly. Now, before we get into the clinical specifics, just a quick reminder to press follow on the show so you don't miss any of our future board revision material. And please rate it if you learned something today.
Yeah, that really helps us out.
Also, remember, you can get a premium subscription to listen to our dedicated journal club and clinical cases deep dives. I mean, it is a huge resource for exam prep.
It really is.
Yeah.
But let's jump right into today's topic.
Okay, let's unpack this. The sheer clinical gravity of this topic cannot be overstated. We are looking at pressure ulcers developing in 3 to 14% of all hospitalized patients.
Which is a staggering volume of patients when you really think about it.
It is. And when you look at the elderly population, this pathology is associated with a 5-fold increased mortality rate. In fact, up to a third of those elderly patients who develop a pressure ulcer will not survive their hospital stay.
Yeah, it's a massive drain on healthcare resources and undeniably a critical component of the plastic surgery boards.
So let's start with the basics. And that means cleaning up our terminology. In clinical practice, you still hear the terms bed sore and decubitus ulcer thrown around constantly.
Oh, all the time on the wards.
Right. But we really need to scrub those from our vocabulary, don't we?
We do. What's fascinating here is that the etymology of our own medical terminology often actively misleads our clinical understanding.
How so?
Well, the term decubitus derives directly from the Latin word decumber, which translates literally to, well, to lie down.
Right, but not all patients with these ulcers are lying down.
Exactly. Using decubitus ulcer or bedsore is factually incorrect because it completely ignores a major, highly vulnerable patient demographic.
You're talking about seated patients.
I am. Think about ischial ulcers. They classically occur in paraplegic patients in wheelchairs, not those lying down in a hospital bed.
That makes perfect sense.
So the only medically accurate, all-encompassing term you should be using in your exams and your charting is simply pressure ulcer.
Just pressure ulcer. Got it. And that makes sense, especially when you consider the anatomical distribution. The vast majority of these ulcers present below the umbilical level.
Overwhelmingly so.
If you look at the literature ranking them in descending order of frequency, the sacrum is first, followed by the heel, the ischium, the elbow, the malleolus, the trochanter, the knee, the scapula, and finally, the occiput.
And as a quick clinical pearl for everyone listening, we have to remember that pressure ulcers aren't exclusively caused by body weight against a mattress or a wheelchair.
Right, medical devices. We see localized pressure injuries all the time from those.
Absolutely. A rigid nasogastric tube taped too tightly against the nasal ala can cause a full-thickness ulnar defect in just a matter of days.
Which brings us to the pathogenesis. We generally divide the driving forces into extrinsic factors and intrinsic factors. Can you break down the extrinsic side?
Sure. On the extrinsic side, the primary culprit is direct pressure leading to tissue ischemia. Prolonged pressure literally occludes the capillary beds.
Because the external pressure exceeds the capillary closing pressure, right?
Precisely, which is usually around 32 millimeters of mercury. When that is exceeded for sufficient duration, you get ischemia, which cascades into necrosis and ulceration.
But a vital concept for the boards here is the inverse relationship between pressure magnitude and time.
Yes, that is heavily tested. A very low amount of pressure applied over a continuously long period of time causes tissue death just as effectively as a massive amount of pressure applied over a short window.
And when we talk about the depth of that necrosis, this is where we need to visualize the classic tip of the iceberg effect.
It is a phenomenal visual for surgical planning.
Because necrosis does not start at the epidermis and slowly burn its way down to the bone, does it?
No, it actually happens in reverse. It occurs first in the tissues closest to the bone, the muscle layer.
Because muscle tissue is highly metabolically active.
Right, so it is far more sensitive to hypoxia than the overlying skin. The skin necrosis happens much later in the process.
And usually to a significantly lesser degree than the devastating damage in the deeper tissues. This creates that characteristic cone-shaped wound.
Exactly. So when you are evaluating a patient on the ward, The degree of visible skin loss you see at the surface is truly just the tip of the iceberg.
There is often a massive cavern of necrotic muscle hiding beneath intact-looking wound edges.
That three-dimensional understanding of the wound is critical. Now, alongside direct perpendicular pressure, the extrinsic forces also include shear and friction.
Let's distinguish those. Shear is mechanical stress applied parallel to the skin's surface, right?
Yes. Think of the classic ward scenario where a patient's bed is elevated and they slowly slide down the mattress,
The skin of their sacrum stays gripped to the bedsheet.
but their skeleton and deep fascia slide downward. This parallel stress physically stretches, kinks, and tears the perforating blood vessels traversing the subcutaneous fat.
And when shear is present, it requires only a fraction of the normal pressure to cause total vascular occlusion.
Exactly. Friction, on the other hand, opposes the movement of one surface against another,
Like when a patient is physically dragged across a bed rather than lifted.
or when they are wearing ill-fitting shoes that constantly rub. Mechanically, friction results in the direct stripping away of the epidermis,
It removes that protective barrier.
which can rapidly accelerate the larger process of pressure ulceration by allowing for local infection and fluid loss.
So those are the extrinsic forces. Then we have to evaluate the intrinsic factors that propagate this injury. Advanced age, immobility, and profound illness are the baseline risks.
But for your exams, you need to focus heavily on nutrition and perfusion.
Impaired nutrition and hydration are major drivers. You're looking for low lean body mass and systemic anemia. Without the building blocks for tissue repair, the skin simply gives up.
Impaired perfusion is equally critical. You have to aggressively evaluate the patient's background.
Do they have poorly controlled diabetes, a massive smoking history, peripheral vascular disease?
Or are they currently sitting in the ICU on a heavy dose of vasopressors? All of these factors severely clamp down on peripheral blood flow.
Leaving the skin starved and incredibly vulnerable. Let's also talk about skin moisture, because managing it is a very delicate balancing act on the wards.
It really is. Excessively dry skin cracks and fails, but excessively moist skin, most often due to urinary and fecal incontinence, macerates the epidermis.
And actively contributes to rapid breakdown, which transitions us perfectly to how we actually classify these wounds once they develop.
We use the EPUAP and NPUAP classifications, the European and American advisory panels.
And there is a very specific phrasing distinction you need to nail for the boards here. We use the term category instead of stage.
Yes, the word stage historically implied a linear progression, almost like cancer staging.
It incorrectly implies that pressure ulcers progress sequentially from stage I to IV.
Yeah.
And more dangerously, it implies that they heal backward.
Right, shrinking from a stage IV down to a stage I, which is anatomically impossible. A deep muscle wound never becomes a superficial epidermal wound again. It fills with scar tissue.
So category is the accurate terminology. Let's break those categories down. Category I is non-blanchable erythema.
Meaning intact skin with redness of a localized area that does not turn white when you press on it.
But here is a practical reality. In patients with darker skin tones, blanching might not be visibly apparent at all. You can't just rely on color.
Good point. You have to physically palpate the area for localized warmth, induration, or a change in tissue consistency compared to the surrounding skin.
Category 2 is partial thickness loss of the dermis. This presents as a shallow, open ulcer with a red or pink wound bed.
Crucially, it will not have any slaw. It might also present as an intact or ruptured serum-filled blister.
Then category 3 is full thickness skin loss. You have lost the dermis entirely. Subcutaneous fat may be visible in the wound bed, but you will not see any bone, tendon, or muscle exposed.
And then category 4 is full-thickness tissue loss. This is the heavy-duty wound where you have directly exposed bone, tendon, or muscle.
You will often see slaw or thick, leathery eschar present here, which brings up a notoriously tested clinical rule.
Yes, if slaw or eschar is obscuring the base of the wound, it is considered unstageable, or rather, uncategorizable.
You simply cannot accurately assign a category to a wound if you can't see the bottom of it. The true depth remains a mystery until that eschar is debrided.
Now, before a patient ever reaches a category 4, we rely heavily on risk assessment tools to intervene.
The literature discusses the Norton score and the Braden score. But for those sitting the FRCS in the United Kingdom, what is the standard?
The Waterlow score is your absolute gold standard. It was updated in 2005 based on new research and remains the most widely utilized tool across the UK.
Instead of reciting the entire scorecard, let's talk about why it weights certain things so heavily. Patients are scored on BMI, skin type, sex, age, continence.
But the special risks categories where scores really jump, things like severe neurological deficits, major pelvic surgeries, or cytotoxic medications.
Because they completely strip away the patient's innate ability to protect their own skin, so how do we interpret the scores?
A Waterloo score of 10 or more means the patient is at risk. A score of 15 or more indicates a high risk, and 20 or more signifies a very high risk.
Demanding immediate, aggressive nursing intervention. So what does this all mean for daily patient care? Prevention is arguably the most massive part of the clinical management strategy.
And let's be honest, it is incredibly labor-intensive.
It absolutely is. It starts with meticulous skincare, a fundamental rule. Never turn a patient onto a body surface that is still reddened from previous pressure.
You have to utilize skin emollients for hydration, apply zinc-based barrier products to fight off moisture from incontinence.
And be fanatic about removing particulate matter like crumbs from beneath the patient.
In extreme, non-healing cases with gross contamination, surgical diversion like a colostomy might actually be required just to give the tissues a chance to survive.
Nutrition is the next pillar. High-protein diets and correcting anemia. Then we have positioning. The goal is to avoid direct contact between adjacent bony prominences.
Heels can be offloaded by placing a basic pillow under the calves, but patients with severe neurological issues are tougher.
Right, a patient with profound cerebral palsy might have constant flexor spasms that cause immense friction, completely undoing all your positioning efforts.
That is where pharmacology and targeted surgical interventions overlap. You can utilize systemic medications like bicalofin, diazepam, or targeted botulinum toxin injections to paralyze the muscles causing the spasms.
And if pharmacology fails,
You look at orthopedic or neurosurgical interventions. Surgical release of joint contractures, a cordotomy, or a rhizotomy to permanently sever the nerve roots.
reducing that extreme deformity is sometimes the only way to allow for safe, flat positioning. Now, repositioning is the classic preventative measure.
It reduces both the duration and the magnitude of the pressure.
The absolute baseline guidelines dictate that bed-bound patients must be repositioned at least every 2 hours. But seated patients are an entirely different beast.
The guidelines state they need to change their position every 15 to 30 minutes.
Trying to enforce a 15-minute turning schedule for a ward full of wheelchair-bound patients is a logistical nightmare.
Which is why technology has to step in. We use alternating pressure mattresses that utilize mechanical pumps to constantly inflate and deflate alternating air cells.
Shifting the load without requiring a nurse to physically move the patient.
We also use low air loss beds, which provide a continuous flow of air through the mattress to actively control skin temperature and humidity.
Directly combating that maceration risk. All of these non-operative interventions are geared toward optimizing the patient.
And many wounds will heal with conservative management alone if you optimize their comorbidities. Control their HbA1c, fix the anemia, enforce absolute smoking cessation.
And rule out malignancy, like a Marjolin's ulcer forming in a chronic wound. You also have to prep the wound bed itself, debride the Escher, use negative pressure wound therapy.
And treat infections aggressively. If probing the wound hits hard bone, you are dealing with osteomyelitis.
Which requires a bone biopsy, prolonged 5E antibiotics, and likely surgical resection of the infected bone.
Exactly.
Here's where it gets really interesting. Let's transition from ward management to the heavy-duty reconstructive surgery. Who exactly gets selected for these massive muscle flaps?
Patient selection is arguably the most highly testable area in this entire topic. Operating on the wrong patient is a guaranteed failure.
Who are the ideal candidates?
Well-motivated, generally younger patients with clinically stable baseline conditions who have demonstrated they will strictly comply with the grueling postoperative measures.
Because if they won't stay off the flap for 6 weeks after surgery, the flap will die.
Right, and the literature specifically points out two groups of patients that are counterintuitively not candidates for reconstruction.
First, patients with deteriorating permanent conditions are treated conservatively. Putting them through a massive physiological insult is doing them a disservice.
Second, and this is the tricky one, patients who are actively expected to increase their mobility are treated conservatively.
So if a patient is recovering from Guillain-Barré and is expected to walk again soon, you don't do a massive muscle flap.
You wait. The rationale is that their ulcer will naturally heal once the localized pressure is relieved by their renewed ambulation.
Let's look at the core principles of the surgery itself. Preoperatively, imaging is paramount. An MRI might reveal hidden disasters like deep osteomyelitis or a dislocated hip joint.
Intraoperatively, the first principle is radical wound excision. You have to cut away the surrounding fibrous scar, any calcifications, and crucially, the underlying bursa.
The bursa is that tough, fluid-filled sac the body forms over a bony prominence.
If you leave it, the ulcer will recur. A great surgical trick here is to inject the bursa with methylene blue dye before you start cutting.
It brilliantly stains the exact limits of the bursal sac so you know exactly how much to excise. Once that massive excision is done, the next principle is the absolute obliteration of all dead space.
You cannot leave a cavern under your flap. It will fill with a hematoma, become infected, and destroy the reconstruction. You have to pack that space with well-vascularized muscle tissue.
If we move to flap selection, how do you choose?
If we connect this to the bigger picture, the overriding philosophy of all pressure ulcer reconstructions is flap economy.
Think of it like a surgical budget. You never spend your entire budget on the first repair.
Pressure ulcers have a notoriously high recurrence rate. You must actively choose flaps that can be readvanced later if the ulcer breaks down again.
You must absolutely avoid violating the blood supply of future potential flaps. You always need a lifeboat. Let's run through the specific defect reconstructions, starting with sacral pressure ulcers.
These occur in supine, bed-bound patients. The workhorse reconstruction here is the gluteus maximus musculocutaneous flap.
It brings a massive, robust blood supply to the sacrum. It has a very respectable quoted recurrence rate of around 16%.
You can design it either as a rotation flap or a V to Y advancement flap. And there is a brilliant modification for non-ambulatory patients.
If the patient is paralyzed and will never walk again, you don't need the gluteus maximus for hip extension.
Exactly. You can completely divide the muscle's tendinous insertion at the greater trochanter of the femur.
Which completely releases the muscle, allowing it to stretch across massive midline sacral defects without tension.
Alternatively, if you want to save the muscle, you can use lumbosacral flaps based on lumbar perforators or a superior gluteal artery perforator flap.
Next up are ischial pressure ulcers. These are the ones occurring in our seated, wheelchair-bound patients.
The literature notes that recurrence rates are significantly higher for ischial ulcers than for sacral ones, mostly because sitting applies immense concentrated pressure.
Now, when debriding an ischial ulcer, you have to take some of the infected ischial bone. But there is a massive surgical warning here.
Excision of the ischium must be strictly conservative. Only take what is visibly necrotic. If you completely remove the ischial tuberosity, you flatten the pelvis on that side.
This simply transfers all the patient's sitting pressure directly onto the opposite ischium, guaranteeing a new ulcer there.
Furthermore, if you are foolish enough to excise both ischial processes, it is catastrophic. The pelvic floor drops, and sitting pressure is transferred directly to the perineum,
resulting in severe perineal ulceration and the formation of horrific, complex urethral fistulas.
To reconstruct an ischial defect, you can use an inferior gluteal artery myocutaneous flap or a V to Y advancement based on the hamstring muscles.
The major advantage of the hamstring V to Y is that it perfectly adheres to our principle of flap economy.
If the ulcer recurs, you can often just re-incise the V, advance the hamstring muscle further superiorly, and close it again.
But you cannot use a hamstring flap in an ambulatory patient because taking the hamstrings creates a severe functional deficit in knee flexion.
If the patient can walk, you preserve the hamstrings and opt for a posterior psi fasciocutaneous flap instead.
Moving laterally, let's look at trochanteric pressure ulcers. These arise over the hip bone in patients who constantly lie on their side.
Often as a direct result of severe hip flexion contractures. The classic reconstruction here is the tensor fasciae latae, or TFL, flap.
It provides a thick, durable paddle of fascia and skin. You also have the option of a pedicled anterolateral thigh flap.
And if the defect is incredibly deep, you can include the vastus lateralis muscle with the ALT to fill the dead space.
We also have to address the nightmare scenario where trochanteric or ischial ulcers lead to frank hip joint exposure and pyogenic joint destruction.
When the hip joint is destroyed by infection, you have to perform a girdle stone procedure,
which involves the complete surgical resection of the femoral head and neck to eradicate the infected bone.
And doing a girdle stone creates a massive dead space. You typically close this by harvesting a massive amount of the vastus lateralis muscle and packing it into the joint space.
For smaller defects, you might get away with the rectus femoris muscle, deliberately preserving the vastus lateralis for a rainy day.
Again, adhering strictly to flap economy. Finally, we have to talk about the absolute last resort.
The end of the line for patients suffering from multiple severe concurrent pressure ulcers where all other flap options have failed.
The fillet of thigh flap.
The fillet of thigh. It is exactly as extreme as it sounds. This involves the literal subtotal amputation of a patient's leg.
You amputate the limb, but preserve the femoral vessels, allowing you to unfurl the entire skin and muscle envelope of the thigh.
And use it as one massive, continuous, well-vascularized flap to cover the entire pelvis.
It is a colossal undertaking, a massive physiological hit with enormous risks due to surgical time and massive potential for blood loss.
It is truly a salvage procedure of the highest magnitude, done to save the patient's life from overwhelming sepsis when literally no other options exist. To quickly summarize the enormous amount of ground we've covered today, we track the pathology from deep tissue ischemia out to visible skin defects.
We reviewed the brutal logistical realities of conservative prevention methods.
And we walk through the exact, uncompromising surgical reconstruction principles from flap economy down to massive life-saving surgeries like the fillet of thigh.
This raises an important question. When we consider that the human skin is an incredibly resilient organ capable of defending our bodies against so many environmental hazards, isn't it profoundly ironic that simply lying completely still in a hospital bed can become its greatest mechanical threat?
It is a striking irony.
It really makes you wonder how future bioengineering might change this landscape entirely. Perhaps we will see smart sensors embedded directly into hospital sheets that monitor subcutaneous capillary perfusion in real time.
Alarming nurses before ischemia ever occurs.
Or maybe advanced, highly durable synthetic skin grafts will render the mechanical root causes of these ulcers obsolete. Someday, these incredibly complex, heavy-duty flap surgeries we just detailed might become entirely a thing of the past.
That is a brilliant and hopeful perspective on the future of plastic surgery. Thank you for joining us for this deep dive. As always, we want to hear from you. Drop a comment or a question below about what stood out to you the most regarding these intense surgical interventions, or how you actually managed to enforce these preventative strategies on your own busy wards. Keep studying hard, good luck with your FRCS prep, and we will catch you on the next one.